So good afternoon once more. I think the hub seemed to have been experiencing a network error. So we went off air, so to say. So I think I was introducing Dr. Duncan Chanda, who will be presenting a case on cryptococcal meningitis. Okay, so we have to start everything. Okay, so good. Is that fine? Yes, all right. I think we are on.
Yeah, sorry about that. Anyway, I'm going to share a case, one of our patients we had on the ward. This is a 19-year-old male who defaulted on their HIV treatment 3 years ago. This patient presented to us about 3 weeks ago with worsening headache over a period of 3 weeks, double vision for a week, and vomiting for 2 weeks. And they had other, there was lost weight and there was some fevers. The patient had previously been on ART from 2014 to 2016.
Try to speak up.
Yeah, from 2014 to 2016, and then stopped due to side effects. And he was a boarder at school, and so couldn't continue his medication. Unfortunately, he presented to us, and that presentation was already on TB treatment, having had that diagnosis about 4 weeks prior. Next slide. So he was on treatment for TB at this point, and on examination was noted to be allayed with the right eye squint and the double vision in the same eye. He had some neck stiffness and tendon reflexes. Other systems were basically point.
Okay, so thank you very much. I think we have heard the case, but just for those of us who might not have get completely. So this is a 19-year-old boy who was referred to UTH about 3 weeks ago. He's a non-RVD patient who defaulted treatment 3 years earlier. By the time he was in boarding school due to side effects, and he figured that he was going to restart himself after he completes his studies, which was last year in December. So the presenting complaint was a worsening headache over a period of 3 weeks, vomiting over a period of 2 weeks, and then double vision for about a week. Like we said, he was an ART, which was TOE, which he started in 2014 and stopped in 2016 due to extreme dizziness. Then 4 weeks prior to presentation, he was started on ATT based on chest X-ray. Currently, at admission, he denied history of fevers, sweats, or chest pains, but he gave a history of weight loss. Drug history was on 4 FTCs, and then he stays with his parents after completing school. On exam, he was alert with a right eye squint and double vision, neck stiffness, brisk tendon reflexes, and other systems were normal. When I'm sure we have been presented with such kind of a patient, and we would like to know what exactly do you do when such a patient lands at your facility. So we would like to hear from you, Kaoma District Hospital. What would you do next for this patient? Kaoma?
Yeah.
Kaoma, are you with us?
We are with you. We are with you.
Yes, yes. What do you think should be done next for this patient?
We can do the vitals. We do a lumbar puncture as needed here. So at least we rule out other differentials. The lumbar puncture and do full blood count on his LFTs, just baseline.
Okay, so thank you very much. So Kauma suggests doing a lumbar puncture. Zaf, I know that you are connecting with us and it's nice to see all the clinicians there in military uniform. Zaf, what do you think you could do for this patient if you were to have such a patient?
25. 25, 132.
Chatonda, please mute everyone. Zaf? Do you want to ask another? Jetta, any thoughts? I hope the people at Jetta district are not running away from the. I've seen some movements there. Any thoughts on what to do for this patient? In addition to the lumbar puncture that has been suggested by Kaoma district.
Can we come in?
Okay, so Yetta's just joined. Dr. Chanda.
All right. Briefly, sorry about that poor internet connectivity. Yeah, so basically we are going to be confronted with this kind of patients, and broadly, probably you want to, if your first thought is meningitis, you're thinking either cryptococcal meningitis or TB meningitis. We still have cases, of course, presenting like this with bacterial meningitis. Ideally, you want to do imaging, including a CT brain or MRI. In this case, I think we went on and did a CT scan. And then this patient, because of the eye symptoms, probably want, if you have access to an ophthalmologist, want to do a fundoscopy. Concerning usually is the possibility of high intracranial pressure. From experience, however, that shouldn't be a barrier to the diagnosis. You go on and do a lumbar puncture. And if you are thinking about TB, you know you're going to ask for your cultures and ask for the expert. However, in terms of cryptococcal meningitis, your first test probably is a serum cryptococcal antigen test or a crack test, which has a very high sensitivity approaching 100. The other test which is available in the laboratories is India Ink, which again has a very high sensitivity. And if the lab is able to do a culture, they still go on and do a culture. So broadly, they'll try and do a gram stain as well to make sure that they exclude other causes of meningitis. Then you need baselines, like you said, yes. I mean, there was the issue of baseline, that's a full blood count and differentials, and then you want to look at your liver function tests and also renal function tests, as these have a bearing on the...
So in this patient, they were done.
So in this patient, they were done. Sorry, trying to see. And broadly, the patient had a pancytopenia of moderate grade, and then Cryptococcus was seen on gram stain. Rather, yeast cells were reviewed on gram stain, and the India Ink confirmed Cryptococcus. I think on the first test, the CT brain was actually normal. I think the next slide. Now I would like to...
Yeah, so some further question is, how do you manage this patient? Lewanika General Hospital, how are you managing such a patient with positive India Ink for Cryptococcus and positive CSF crack? Any thoughts? Lewanika General. Sorry, we cannot hear you. Move closer to the mic.
I guess.
So I think you start on amphotericin B for 14 days. Then you add flu cytosine and corners the same period.
Okay. So are you having flucytosine at Lewanika?
We don't have.
So what are you doing? We want you to share your experiences from there. In terms of what exactly are you doing, not what should be done.
We treat using amphotericin B for 14 days. Then we add fluconazole. We have a dosage of 400 milligrams a day.
Okay. So are you adding after the amphotericin?
During the amphotericin period.
Okay. Monze Mission Hospital, is there anything different that you're doing or anything else in managing such a patient who presents with a worsening headache, diplopia, and vomiting? Apart from adding the insertion phase for management of Cryptococcus. Monze, are you with us? What about the first level hospitals in Lusaka, like Chilenje? I'm sure we are encountering such patients. Chilenje, can you come through and share your experiences of how we are managing this type of patients, apart from just giving amphotericin and fluconazole? Chilenje, are you with us?
We can move on. Don't have time.
Okay. So, Dr. Chanda.
Good. So the principle for management in cryptococcal meningitis includes 3 stages. That's of induction, consolidation, and then maintenance stage. However, prior to that, pay attention, particularly the general condition of the patient. In this case, the patient was mildly anemic, which is fine, but at times we're going to have patients with a low HB, so we want to do a transfusion. Then, as a matter of principle, every patient has to be hydrated before you start giving amphotericin B. So you hydrate with maybe half a liter to 1 liter of saline, normal saline, and then you run the amphotericin B over 3 to 4 hours. And then after the amphotericin, you again rehydrate the patient. Yes, as part of induction, you also start high-dose fluconazole. I think our Zambian guidelines mention 800 milligrams. You can actually go much higher, as we have proven in recent studies. You can go up to 400, but current guidelines in Zambia, you give 800 milligrams of fluconazole alongside your amphotericin at 0.7 to 1 milligram per kg body weight. Then the next stage will be that of consolidation. That's where now you give the...
So Dr. Chanda, maybe since we are going to talk about the exact protocols in the didactic, just about the principles of how to approach this patient. Yeah. So there's the treatment with amphotericin.
And then there's the monitoring.
And the monitoring part, especially the monitoring. How do we go about it?
The interesting... I think the important part here is to realize that both amphotericin and fluconazole can have serious side effects. So you basically monitor the renal function on at least 2 to 3 times a week. Then you also have to minimum a weekly full blood count so that you check for anemia. And basically those two are the main principles. You are going to have other issues. I think maybe we shall talk in detail in terms of how the patient is responding basically to the treatment itself. Okay, so this patient We kept this patient on the ward, and 10 days later, the patient had a seizure, which was quite concerning, given that the patient had been on treatment for 10 days. And then when a lumbar puncture was repeated, the gram stain yielded yeast2+ Indian ink was positive. At this stage, the CSF showed no growth. And notable also, you had raised the sodium and the hypokalemia, which is, again, it's important that you monitor potassium levels in these patients because they'll need potassium chloride supplementation, or if you don't have, you could use slow care.
And just maybe to put you, Dr. Folosh, on the spot, issues of increased intracranial pressure in cryptococcal meningitis. There's a lot of discussion of exactly what should people do with increased intracranial pressure. How do you manage intracranial pressure?
So ideally, if you need to do serial lumbar punctures. In our setting, we tend to use clinical signs, which are a worsening headache, new onset neurological pressure, the eyesight and a long ruler, and it can actually go up and give you the pressures. The other thing is if you fail to control it using serial lumbar punctures, you can even put in a shunt. You can consult the neurosurgeons, they can put in a shunt.
Okay. What about patients who suffer a seizure? Is it an indication to refer to UTH?
Ideally, you'd need to actually attempt to do a lumbar puncture. If they do not abate after a lumbar puncture, then you can maybe consider referring the patient for a possible shunt, or maybe for a CT scan in case there are other issues that have set in. Okay,
so thank you very much. I think this is a patient, Dr. Chanda, you managed. How was the prognosis for this patient?
So unfortunately, we lost this patient just after finishing the induction. And subsequently, the patient was discharged, but then the patient died. About the whole issue about high mortality in cryptococcal meningitis, despite the availability of various medications.
Okay. Yeah. So before we go to the didactic for today, are there any questions from the network? Do we have any questions? Oh, so there's a question from Leonard. What was the CD4 count for the patient?
So the CD4 count the last lumbar puncture, which I'm down by then. I think sustained intracranial pressures is a very bad marker, and also any neurological deficits like this we saw in this patient. Usually that's a worry. We corrected the potassium at the time of discharge and encouraged the patient to take food rich in potassium. We're not really sure at the end of the day.
I agree with you. So one of the other things that's a bad, and that low white cell,
yes,
it's a bad prognosis.
Because
I don't know if anyone who has seen. Would it be appropriate to do a resistance testing? Sorry.
That's fine.
Yeah, we'll come back to you. So this is a question from Nangongwe. Would it be appropriate to do a resistance testing? Dr. Chanda, your patient.
Resistance testing for what? For HIV?
For cryptococcal.
For cryptococcal.
For amphotericin.
So resistance to amphotericin B is very rare. It's very rare, and there's no need for you to do resistance testing. Let's get.
Okay, so there's a question from the hub. Yes, sir, please go ahead.
The question is, since there was a mention of having this patient having TB,
Yes.
and it was 4 weeks on treatment, just assuming that maybe if it was a core TB meningitis and the crypto, was the prednisolone among the...
So he's asking whether this patient was actually on a corticosteroid for the TB. The TB wasn't TBM actually. It was it was pulmonary TB. Yeah. So I could still go on and answer the other part. I've seen doing managing 50% of the patients who have both steroids. Okay, because the outcome, we're going to discuss this later on, for cryptococcal meningitis, all the studies have shown every time they added corticosteroids, the outcomes were worse. Yeah.
So I bet this answers, I think, a question from Livingston, which was asking if the patient, we should have added a steroid on top of the lumbar puncture, the serial LPs.
No.
So I think it adds that if you add the steroid when there's cryptococcal, the outcome is worse. Kaoma is asking if fluconazole only.
I think we'll
definitely discuss.
That's a good question.
And then what was the third stage of management? This is also going to come in the didactic. So thank you very much. I think now we can move to the didactic presentation, which again will be led by Dr. Chanda.
Just make sure I find it. Are we?
Yes.
So that we didn't.
Don't worry.
Okay. Yes.
As Duncan is setting up, I just get the feeling that Nangongwe's question was, is it necessary to do resistance testing in patients who've been on SS? Is it necessary to do resistance testing?
Okay. I think I'll leave Francis to answer that.
Okay. So the question wasn't clear whether it was resistance testing for HIV or for cryptococcus. But if it's for the HIV, we know that this patient initially was on TLE and stopped. So definitely it won't be cost effective to do a resistance testing in this patient, because we would know what sort of mutations they would have had if they failed. And definitely after 3 years, they would have gone back to the wild type, and it will show that there's no resistance. So absolutely, it would be absolutely unnecessary to do a resistance testing after 3 years of someone not taking ART. But with regards to amphotericin, like they said, resistance to amphotericin is very rare. And this patient on day 10, the fungal culture was actually no growth. So meaning that what was being seen were dead fungus, which will show positivity on Indian ink, but it doesn't mean that they are still alive. So if they happen that's to have been alive, of course, a few studies have done resistance testing, but this can only be done in advanced test centers like ours. And very few actually samples will come out positive. I can see another question, I think. Is it something, Mr. Chatonda, that you can assist us? Because we can't have it here. I don't know, can't see it here.
I can't see from here.
You can't see the slide?
No, here the question is not there. I don't know why. Okay, I think
there's a question.
Oh, no, it's just a comment. They were saying.
Oh, okay. All right. So, Dr. Chanda, I think we can now go into your presentation.
All right. So we have three main learning objectives. That is to describe the recommended screening and prophylaxis for cryptococcal meningitis, identify the fungal management of cryptococcal meningitis, including secondary prophylaxis, and then the third one is to discuss the issue of timing of ART in patients with cryptococcal meningitis. We have got a couple of polling questions.
Yeah, they are embedded. I think Dr. Chanda is used to by-elections. I hope that you don't turn one into a by-election.
Yeah.
Mr. Chanda, you help us put up the poll question. So the first polling question is, which one of the following is true according to the Zambia Consolidated Guidelines 2018? A, cryptococcal antigen test must be used for screening for cryptococcal antigemia in all HIV positive patients regardless of the CD4. B, cryptococcal antigen screening is only recommended in patients with CD4 less than 100 and less than 100. C, lumbar puncture is indicated in patients with positive serum CRAG. And then D, a serum CRAG should be done on all symptomatic patients. So we can start the polling. I can see that it's up.
Want to read through them again?
So the question is, which one of the following is true according to our Zambian Guidelines 2018? Cryptococcal antigen tests must be used for screening for cryptococcal antigemia in all HIV patients regardless of the CD4. Then B, cryptococcal antigen screening is only recommended in patients with CD4 less than 100. Then C, lumbar puncture is indicated in patients with positive serum CRAG. And D, a serum CRAG should be done on all symptomatic patients. So we can see at least 20% have voted. Please, let's answer that poll. We are getting there, about 26 out of 39. Let me see the next one. Dr. Chanda, do you want to make comments?
I think I'll.
So we've got about 38% going for D, 35% for C, 8% for B, and 19% for A.
All right. So I should comment that I think the question could be a little bit tricky given the way we have put the how the Zambian guidelines come out across screening. So by and large, screening is recommended in patients with advanced HIV. The sensitivity of the screening for CRAG in higher CD4 is very poor. Okay, and not only that, we know from the pathophysiology of cryptococcal meningitis that most people who have cryptococcal meningitis when the CD4 is less than 100, and so therefore it becomes cost effective. And I think that's what our guidelines are also advised. We'll discuss the issues of preemptive treatment later on. A serum, a positive serum CRAG, that's C. Okay. What one would want to do then is to elicit for signs and symptoms of meningitis, and if they're positive, you proceed then and do a lumbar puncture. Okay. I know that in some cases we have received a number of patients nowadays with only a positive serum CRAG from other hospitals, and at times these patients are symptomatic. We'll discuss this again later on, that serum CRAG is a good predictor for a positive CSF antigenemia. Yeah, so no, CSF for rather cryptococcal meningitis if you have a serum plaque. Okay.
So we move next. My slides are not moving, Chatonda.
Which slide are we on?
Okay, it has moved.
It has moved. Okay, so we'll briefly talk about the background of cryptococcal. There are various numbers which you will find being thrown around, but 2014, WHO was estimating about 223,000 cases of HIV-associated cryptomeningitis with a mortality of about 181,000, which is very high. Okay, so in settings where they're just using fluconazole monotherapy, which we'll come to, the mortality at 3 months approaches 80 to 90%. So it's as good as we're not giving anything. Yeah, so, and we know that most of the cases of crypto are actually in high HIV prevalence countries such as Zambia and other areas around here. A previous study done at UTH showed 100% mortality at 12 months if the patients were not treated at all. These were early years when we actually didn't have any antifungal drugs. If you have a very effective treatment options, you reduce that mortality to 30 to 40%. However, this is in very good hospitals, largely in the high-income countries. That's why you get the 30 to 40%. Here, under clinical trials, we were in the range of 45%. But in the hospital setting, basically, the mortality still approaches 50% to 60% in Zambia. Okay. So the presentation usually occurs with a low CD4. It's not really necessary that your CD4 should actually be measured. There is a way of looking at, for instance, a Cryptococcal performance scale. I think previously we had shown a performance scale anything less than 5/10 correlates very well to very low CD4. And also it showed very high prevalence of cryptococcal meningitis in this group. Usually the symptomatology, is develops slowly over weeks, as opposed to bacterial meningitis, which will be very acute. They will complain of headache, hearing, visual problems. There are usually some confusion and fever. Okay. Next.
Okay, so the second core question is as follows. Which one of the following on diagnosis of cryptococcal meningitis is true? A positive serum CRAG on routine visit in a patient with CD4 less than 100. B, positive CSF CRAG in a patient with a headache for 2 weeks. So the polling question is as follows. Which one of the following is true on diagnosis of cryptococcal meningitis? A, positive serum CRAG on routine visit in a patient with CD4 less than 100. B, positive CSF CRAG in a patient with a headache for 2 weeks.
I think they changed them.
Did not change.
They didn't change. Oh.
It's okay.
Sorry.
You can say no, the truth.
Yeah. We've got close to 50 people voting. Okay. The only thing is that I'm only seeing one side voting. I don't know, Mr. Chanda. I'm seeing A has got 72% and then A has got 28%. Yeah. Almost everyone is voting, which is, wow, I think 100%, 71% voting.
Okay.
Yeah, so the majority have gone for B.
Okay, B.
Yeah.
All right. This one sounds, I think, much easier. So this is true. I'll go for B myself. A positive CSF CRAG in a patient with a headache for 2 weeks. The option of A, while tempting, really, the problem here is the patient has a confirmed antigenemia. He has cryptococcal antigen in blood. The only important thing about this is they progress to cryptococcal meningitis on an average of 22 days. A big cohort study in Uganda showed if someone had the serum CRAG positive and the low CD4, by 22 days on average, these people would progress to cryptococcal meningitis. So if you are unable to do a lumbar puncture in this case, you're a little bit tight, though probably we're going to change in the future on how you're going to treat such a patient. So B is a straightforward case that this is cryptococcal meningitis by a positive CSF CRAG in this patient. Okay. Can we go next? Yeah, thank you. So just to mention, the antigen test has a sensitivity about 98 to 100%, really depending on which version you're using. I should mention that there are other antigen tests that use urine, which are under development. Okay, so the serum antigenemia predicts progression to cryptococcal meningitis, with one study in Uganda showing this to occur at a median of 22 days. All patients with a positive serum test must be evaluated for signs and symptoms of cryptococcal meningitis, and a lumbar puncture should be done to exclude or confirm cryptococcal meningitis. So we previously carried out a community study here in Lusaka at level 1 hospitals, where we screened people initiating ART. We screened for cryptococcal antigen tests. And for those who had some symptoms, we tried to persuade patients to do the lumbar puncture, which wasn't so successful in terms of someone with a positive serum CRAG and moving on to the lumbar puncture. However, we, as an intervention, we still treated them with high dose fluconazole. The results were quite promising because the overall reduction in mortality in that arm where we did the presumptive treatment, the reduction in mortality was about 28%, if you can check out the REMSTAT trial. Yeah. Okay, so other things you can do, the physical examination to look for signs of meningism, and you look at tendon reflexes. Some people do pay much attention to rashes on the body, which could give a clue. I'll tell you that personally, I've found that very helpful. Yes, so you expect a raised WBC probably, which is good. In our patient, one who presented, as you noticed, the CSF WBC was 0. You usually expect raised proteins, and the glucose will usually be within normal. And depending on what the lab uses, here the lab uses the India ink and also a cryptococcal antigen simultaneously, and often they'll still go on and culture. Okay, next. And those alluding to some of the localizing signs that you're going to see. Okay, next. So the treatment, now here probably I should go over this very carefully. So treatment is in 3 stages: the induction stage, the consolidation stage, and maintenance stage. From anecdotal data, we observe that we are not sticking to all the 3 stages, especially the last one. That's the secondary prophylaxis. So patients usually they're going to get a very good induction therapy with amphotericin B at 0.7 to 1 milligram per kg per day, alongside fluconazole. This is for 14 days. Okay, like we stated, the infusion should be over 4 hours. Always rehydrate before and after giving amphotericin B. So the induction stage is followed by the consolidation. Okay. So previously, and because our guidelines in this area are quite old, the consolidation was 400 milligrams once a day for 8 weeks, and then we follow up with 200 milligrams until immunorecovery. That's the term we're using now. I should mention that the current WHO recommendations for those who might get confused with this, actually they recommend a higher dose for induction, meaning you use 1,200 milligrams of fluconazole, and then for consolidation you use 800 milligrams, and then you come to 200 milligrams for secondary prophylaxis. But for the Zambian guidelines, I think, so why am I mentioning this? 400 milligrams is fungistatic, okay? And 800 milligrams and going up is fungicidal. Okay, so you're going to find yourself in a situation where you want to maintain a high dose despite you having finished the consolidation. Okay. That dose of 800 to 1,200 milligrams OD for 14 days, and then you taper down. But then even these, the mortalities are untolerable, but given the situation, you'll be in a rural area, the patient cannot get to the next level, a very high dose of fluconazole. I know some studies have gone up to 1,800. Yeah, so one of the worries about high dose fluconazole is the QT interval prolongation. So in our study previously, I think we did ECGs in the first 150 patients, and we didn't find any difference between those one high dose fluconazole and those one not on fluconazole for that period. Yeah. Very important. Let us not just concentrating on giving the drug or the drugs in this case, but we have to monitor for the side effects. Hypokalemia is very concerning. Some people advocate prophylactic potassium supplementation alongside magnesium supplementation, which is what we did in the ACTA trial. So you check for erythrocytes and you check for creatinine twice weekly. At least you do complete count weekly. I think someone did mention flucytosine. If you're using flucytosine, this is very important as well because it can cause neutropenia. Okay.
Question. The following are true concerning the management of cryptococcal meningitis. A. Start CART as soon as diagnosis of cryptococcal meningitis is made. B. Start CART after 2 weeks of insertion phase. C. Delay CART after 4 to 6 weeks of starting treatment during the consolidation phase. D. Start CART to avoid iris. So we can go ahead and give our poll on your screen. The following are true concerning the management of cryptococcal meningitis. Start CART as soon as diagnosis of cryptococcal meningitis is made. B. Start CART after 2 weeks of insertion phase. C. Delay CART after 4 to 6 weeks of starting treatment during the consolidation phase. And then D. Start CART after completion of consolidation. That so far, of us, if we are convinced to believe that it's network, still getting more answers, please go ahead. So far, only 7% have gone for A, 30 have gone for B, about 44 for C, D about 18%. Or there are voters behind. Okay, so thank you very much. I think we can end the poll. Dr. Chanda, any comments on? So I think the majority have gone for C, and then followed by B.
B, 2 weeks.
And the list is A.
Okay. So at least A we know. Okay, so the recommended time to really start initiate ART, and in this case, like the previous patient we presented, the idea was we're going to delay at least 4 to 5 weeks. So I think our guidelines mentioned 4 to 6 weeks as well. WHO 4 to 6 weeks. So the risk for iris or paradoxical deterioration of the patient with cryptomeningitis, if ART is initiated early, is very high, and the mortality in early initiation of ART in cryptococcal meningitis is very high. Unlike TB meningitis, also because in TB meningitis, there's that recommendation that you delay the ART, but in TB meningitis, you could probably start by week 3. In crypto, basically, the earliest you could start is by week 4. In the patient who presented, because they've been off ART for that long, we are still going to delay ART. We are planning to initiate ART in 4 to 5 weeks' time. So basically, in terms of test and treat, this is where you don't test and treat. You treat the meningitis for 4 weeks, and then you come and initiate the ART. Remember, mortality still remains very high at 10 weeks when you are starting your ART.
Okay, so thank you very much. I think just a reminder, we would like to see the faces who have joined, so kindly make sure that the videos are seen. We've seen Lundazi, so many. I don't know if it's the network issue, but please, if you're having network, make sure that your video is on. We want to see you just as much as you are able to see us. Okay, next.
So that's a very important message to get in terms of cryptococcal meningitis. Okay. So the other question is primary prophylaxis feasible? I know that one of the previous guidelines was the OIs. There was the issue of giving fluconazole of 200 milligrams OD as primary prophylaxis in people with advanced HIV. However, there is no evidence for this. There's only evidence for treating those with serum antigenemia, and therefore that's how the recommendation comes in. I'd like to hear what sites are doing out there. So some gray areas. These are open to discussion every time we do find ourselves in such areas. There's sometimes the persistence of culture at the end of induction. People should be aware that 40 to 50% of patients will still have positive culture at the end of induction. This doesn't mean that the induction has failed. No. To the contrary, the whole aim of induction is actually is to try and reduce the burden of Cryptococcus in the CSF. And then the half-life of amphotericin is quite long, and it remains effective up to 21 days after you have stopped the drug. So also the toxicities you still have to monitor for that long. So there's no evidence for you to actually prolong amphotericin B induction beyond the 2 weeks unless the really a clinician has another reason. The court trial, actually, they were the first ones to have observed that if a patient had some cryptococcal cultures positive at 14 days, they just extended what they called enhanced consolidation. They just increased the dose of fluconazole and the outcomes were good. So at that time, 800 milligrams was considered to be very high. I'm not sure currently whether we could actually put that 1200 milligrams as high until the cultures clear. Okay. Our Zambian guidelines does I think there's a very small paragraph which was a little bit confusing about screening for cryptococcal meningitis. Okay, there's no mention about preemptive treatment, but basically that's what you want to do. Should we screen or not screen? Okay, so people with advanced HIV, you probably want to screen. We haven't put that clearly in the guidelines. We are hopeful that when we review the guidelines, we're going to put that. I should mention South Africa, they're screening, Tanzania, they're screening, Uganda, they're screening, Namibia, they're screening, and Malawi. So they screen these high-risk patients and then put them on preemptive therapy. Okay. So then, like we mentioned, basically, fluconazole for 2 weeks and ampho for 2 weeks is our induction, then followed by 8 weeks of consolidation and then maintenance. Maintenance is also referred to as secondary prophylaxis because the patient already had cryptococcal meningitis and now we are trying to avoid the relapse. Unfortunately, a number of our patients actually don't even finish 8 weeks of consolidation, okay, largely because maybe a wrong prescription was given, the emphasis wasn't placed on why they have to take that drug. We're still very small number of our patients who actually go on to have secondary prophylaxis, and then they relapse within 12 months, and they come back with cryptococcal meningitis with very poor outcomes. So we should really try to make sure we educate the patient, we educate the family on how we're going to proceed. The induction, consolidation, ART insertion during consolidation, that's why I like putting it, because you have access to the patient. And then the secondary prophylaxis. Thank you. I think.
Okay, so thank you very much. Those were the references. We will now open it up for discussion, comments of the case, and the didactic presentation. So there was an earlier question from Dr. Sokolo Levy. Did you consider the possibility of hypomagnesemia being the cause of the seizure in this patient?
Very good question. We did, but we didn't have actually any results. And with hindsight, probably because of that is grade 3 hypokalemia, we should have actually just supplemented with magnesium as well, and alongside the potassium supplementation. As you are aware, Dr. Nsoko, in the ACTA trial, we actually supplemented routinely with magnesium in all the patients. And in terms of electrolytes, we had very few electrolyte imbalances in that trial.
Okay, so thank you very much. And it's kindly open for everyone to give comments, to ask questions or clarifications on what has been discussed so far. And I think we haven't dwelled much on the criteria for referral, because we have seen most centers, especially those around Lusaka, we don't know elsewhere,
Yes.
if they just find a serum crag positive, it's UTH. Any comment?
Yes, I think a very good comment. I think most of the level 1 hospitals should have amphotericin in their pharmacies, side effects of the drugs. I think it's prudent and practical for you to send a sample twice a week here, whilst you have the patient at your primary facility. It's a very expensive venture to send a patient here and have the whole family moving, probably spending between 100 and 150 kwacha per day just to come and visit a relative in the hospital, when we could do it as close to the family as possible. So yes, so coming to serum crag, if it's positive, please go on, evaluate, and if necessary, do a lumbar puncture, and you can start treatment from that end. And then if you need to monitor, then send samples over here. Yeah.
Okay.
So just to add on to that question, Dr. Duncan, maybe as you in our guidelines, we say treat people serum crack and preemptively treat. I think what we don't do is we don't say the dose, we don't say for how long. So maybe that's why our colleagues are referring these patients. Do you mind?
Yeah, I think I noticed that there's quite a gap in the guidelines. Hopefully, we are going to fix that. So if you just screen for serum crack and this patient has a low CD4, but you are sure they haven't developed cryptococcal meningitis, you can start preemptive therapy with high dose fluconazole at 800 milligrams OD for 2 weeks, and then you taper down to 400 milligrams OD for 8 weeks, and then you proceed again with secondary prophylaxis at 200 milligrams for 2 weeks. You could initiate ART if they're not ART 4 weeks from the time you started the empty treatment, and you can still go on and monitor for side effects. In this case, you are just using fluconazole, so probably you just do weekly bloods. I think it is important that despite that gap in our guidelines, there is this knowledge everywhere from WHO, from IDSA, and also from guidelines from other countries. We reduce mortality if we are going to do preemptive treatment. It's not helpful to have a positive serum and then send away the patient.
Okay. Thank you very much. I think the feedback from Dr. Sokolo is that kind emphasize the potassium and magnesium in the treatment. So probably
the guidelines. Yeah.
Maybe people need to hear it from you, Dr. Sokolo.
Okay. Yes. Thanks, Bright, for that. I think one of the biggest problems is that when we are monitoring electrolytes, we tend to ask for potassium and sodium alone, when we know the effect of AMPHO on the magnesium and how this derangement is actually a serious side effect for the patient. So please, if you're going to monitor the electrolytes, make sure you cover magnesium and you cover potassium, and if replacement is needed, you have to replace those electrolytes as well.
How is the potassium and magnesium supposed to be replaced?
So it depends.
And in what formulation? I think there's a question.
So there is an oral formulation for magnesium. You can give up to 500 milligrams per day. I think some come in 250 and you can give 250 BD. Okay, the potassium, ideally you want to replace the severe hypokalemia. You can use potassium chloride as a replacement. You can do the calculations. But you can also give slow K. Okay, prophylactically, as you start off, you can add that to your regimen. I think in the previous trials we only added potassium chloride. I think starting from day 3, and then magnesium we started from day 1 as a magnesium tablets.
Okay, so thanks very much. I think Lundazi has got a question. Lundazi, please go ahead and ask your question. I've noticed that a lot of us are preferring to type. I think there are a lot of questions which are typed. So please try to raise your hand as much as you can, because we cannot read everything. Ideally, we're only supposed to receive 2 or 3 written submissions. Lundazi, please go ahead.
Right, thank you. The question is on the treatment. We don't know which one should we adopt. We had, we saw the 800 and the 1,200. So wanted the clarity on that one. Then the second call, just a comment in general. We are requesting that the presentations like this shouldn't have all the guidelines. Like we saw some previous guidelines which were still showing the CP4 350 and below. So it's a request that when the presentation are being made, we have the updated information at times. We follow what is being presented. So a clarity on the 800 or the 1,200 for 100%. Thank you.
So in terms of treatment, I don't know whether you're getting the 1,200. I think it's the current Zambian guidelines. Fluconazole for induction is at 800 milligrams, okay, per day. And the amphotericin is at 0.7 milligrams per kg per day. However, I think you're going to find a number of other documents which are advocating for fluconazole at 1,200 milligrams per day. So according to the Zambian guidelines, it's 800, but probably you can use 1,200 as part of induction for 14 days.
Right. Thank you.
All right, Peter, okay, you also had a question. Please go ahead. Peter, okay.
The question they had here was, how do you deal with a client who has crypto but they are pregnant?
So okay. Yeah. Okay, good. Good question.
Their own. Are you ready? Or is it the same question?
That's the question.
All right, you still go on and treat them. We do have such cases on our consult list every maybe once a month. Difficult to say if the mortality is worse, but one gets that feeling. We do still go and treat them because crypto is lethal. We're not going to withhold the treatment. We still use fluconazole and we still use the amphotericin B. Yeah.
Matero level 1, please go ahead with your question.
Yes, our question is, are we still using hydrocortisone for pre-medication before giving amphotericin B?
Aside that question, there was a question, are we still using steroids? The other question of what is the dose of your start doses for ampho B and how long do you give?
Okay. Okay, so the use of hydrocortisone for prehydration?
For crypto. Ampho B.
Okay, we don't.
As a pre-medication.
No, we don't recommend that. Yeah.
So just emphasize it.
It's not anymore recommended, and I think some studies have shown that it has adverse outcomes. So we don't, please. Then dosage of amphotericin is calculated at 0.7 milligrams to 1 milligrams per kg body weight per day. Then it's usually given as an infusion over 3 to 4 hours. Okay.
So I think there was a confusion because some people would say, "Oh no, start small, then you are increasing over 3 days."
So I think
should we do that?
No, I think I saw a test. Someone was asking whether there is a test dose.
Dose.
No, you just start at the
food dose.
At the food dose
from the beginning. Then the pre-hydration is with fluids and no pre-medication with steroids.
No.
Okay, Kazungula was trying to find out. Should you use the same IV line for the infusion of amphotericin with saline as a pre-med and post-hydration?
Yes, ideally, yes. It is also going to reduce the phlebitis, which is associated with amphotericin B.
So it's actually advised to use the same line rather than changing. So I hope that is clarified. Then how long is the maintenance phase for non-reactive patients?
Wow, that's another topic
for another day.
So that's for another day. I'll just mention that if you're going to have a non-reactive, an HIV negative patient, and they have cryptococcal meningitis, you need an ID expert input there because we treat them for much longer, both at induction and consolidation.
So in short, this is one of the definite reasons for referral to ID experts.
Yes.
Any other that you can pinpoint that when you get this patient, please refer apart from just those who are HIV negative?
Off my head, no. Maybe help me.
Dr. Fellowship, any of us, because I think there was a question.
Maybe
that when TB, are there circumstances that say, okay, as a center, let's refer?
Of course, if they are heavily treatment experience, when you have to play around with their drugs, remember fluconazole and things like rifampicin, they can interact and you need to go to higher doses of that. If somebody is having toxicity, especially from amphotericin B, especially the one we use the deoxycholate formulation. So our patients have a tendency to high creatinine. So if you imagine you have a patient with a creatinine of 1,000 and they have cryptococcal meningitis, it happens. That patient you may have to refer because we have to actually dialyze and give the ampho at the same time. And if you have severe hypomagnesemia, severe hypokalemia, those you may have to refer because they need specialist treatment because they can get cardiac arrhythmias.
Yeah, now that you have mentioned the formulation of the amphotericin we are using, I know our colleagues probably, like in the defense forces, they might have access to liposomal amphotericin or amphotericin lipid complex, which are less toxic amphotericins. I know that they are in the pharmacies selling around Lusaka. So if you're going to use these two formulations, which are lipid formulations, they are less toxic and have better outcomes as well. Yeah.
Nakambala, is that a hand that is flying there?
Chilenje has a question.
Okay. Nakambala, if that's not a question, we can move to Chilenje. Chilenje? Chilenje, you are on.
They look muted.
Unmute Chilenje.
Okay.
Yes. For some reason, Chilenje is remaining muted. But their question was, when do you start cryptococcal ART in a case of bacterial meningitis? Not fungal, but bacterial. Because we all know that things like strep pneumoniae, the bacteria are more common in people with HIV. And we do get patients, they come with malaria, you find actually it's HIV as well, they come with bacterial meningitis. When should you start ART is the question.
Well, I've never looked at that. Sounds as soon as possible.
Yes, it starts it's test and treat.
Yeah.
Kazungula has counteracted. I don't know why they should do that, but I think the expert here has advised that you use the same IV line. So I don't know why you insist that you use different IV lines. There is no interaction between amphotericin and saline. Please do as you advised. Actually, you improve the patient's outcome in that they won't develop phlebitis, of which amphotericin can. So this is the expert advice, and you advise to practice as you have been advised. So thank you very much. Which one? Material should be the last question that we are accepting. Please, you can unmute them. I can't see them.
Thank you. There is a question here from Matero.
Yeah. So, Doc, you mentioned that we no longer do the pre-meds and there's no testos. What do we do if patients react to amphotericin B?
First, very good question. Very good question. If they react to amphotericin B, I should mention that I haven't seen one reaction recently. Yeah, you are going to follow the same protocols as any other drug reaction. Okay. The pre-med, which was practiced, I don't know where it came from actually. I found it in hospitals. It has no basis. There's no evidence for that kind of approach. Okay. But there is evidence for you to pre-hydrate the patient, because we know that when you pre-hydrate the patient, then you reduce the effect of ampho on the kidney. And that's why we just encourage pre and post hydration. If the patient reacted, really, you just have to follow the usual protocols for adverse drug reactions.
Just to add on to that, in my clinical practice, when a patient, as I know, usually it's the rigors that we fear, somebody's under the blankets and people are scared to give ampho-P and would even cover it. I think usually it means that it has been run too fast.
Too fast.
So it means that maybe the nurse was not given appropriate reaction instructions, so they ran it too fast. So what I would advise you is to run it slower. Sure. But interestingly, one drug that has actually been shown to have effect is pethidine. Not steroids, not whatever we've been doing, but pethidine actually does lessen that. So if I had a client like that, I would slow down my rate of administering it and give some pethidine and see how that goes. Usually it goes away.
And make sure it's done, because the one thing I've learned, there have been cases where a patient gets those rigors and then you find the dose is missed for that day. Okay?
Okay, yeah. So I think the confusion from Kazungula is now clear. They were thinking amphotericin should actually be given as an infusion in saline.
Oh. In saline, in dextrose.
So they are saying that at their hospital, it precipitates.
I was about to say again, yes, it depends on the formulation.
Okay.
Yes.
So, but the deoxycholate that we have, by and large, we give in dextrose-based solutions. Yes. Mm-hmm. So I think what we were saying is that the pre and post can be given in the same IV line, but the infusion is what you give in a dextrose-based fluid. So I think let's not confuse the infusion and the pre-hydration and post-hydration. And I think that's what we're talking about. The pre and post-hydration can be given in the same IV line, but we are not saying as the infusion. Okay. Yeah. So thank you very much for coming through. And we know that we have slightly exceeded between the targeted time because of the so many written questions which we thought should all be addressed. Next week, we will be talking about the use of TLD and women of reproductive age. See you then. Thank you very much.